Usually, our circulatory system consists of two heart chambers, the so-called ventricles. They pump blood into the systemic and pulmonary vasculature. There is a wide range of heart defects people are born with that result in just one single ventricle. Fontan surgery is the final stage palliative treatment that is performed for most of these single ventricle heart defects, and it connects the systemic and pulmonary vasculature in series using the Fontan shunt. The hemodynamics are not well understood and lead to severe pathophysiological consequences for the patient, resulting in very high midterm mortality rates of 50 to 70%. Blood flow passing through the Fontan shunt is passive from the systemic vasculature into the pulmonary vasculature, which implies minimal pulsatility. However, recent studies have shown that Fontan flow is far from being constant as which it was simulated previously. Instead, respiratory pressures during breathing cause major changes in the flow rates. On the top, you can see the physiological arrangement of the respiratory organs and of the Fontan circulation embedded with those respiratory organs. During inspiration, the diaphragm lowers, causing increased pressures in the abdomen and thus on the systemic vasculature, while pressures in the thoracic cavity as well as the pulmonary vasculature decrease. As up to 80% of our blood is stored in the venous side, the pressure changes squeeze additional blood between the vascular beds to increase forward flow to up to 140%. During expiration, this mechanism is reversed, allowing flow from the higher pressurized lungs into the now lower pressurized abdomen, causing a retrograde flow of up to 30%. This causes major losses in forward flow energy, and it raises pressures on the organs in the abdomen. Thus, it greatly contributes to detrimental health effects on Fontan patients. Mock circulatory flow loops for the Fontan circulation aim to better understand the complex physiology and provide a benchtop platform for device testing. However, current benchtop models fail to imitate the respiratory mechanics that impact the compliant vascular beds. Approaches to model the important influence of respiratory pressure changes are limited to modeling small sections of compliant vessels, as you can see above. Animal models to approximate the flow patterns of the physiological Fontan circulation are highly challenging and focus around sheep and porcine models. The nature of animal models using assisted positive pressure ventilation and open chest cavities prohibits to recreate the interaction between respiratory pressure changes and resulting flow patterns. In this work, we describe the design and fabrication of a biomechatronic Fontan mock circulatory loop guided by anatomy. We recreated Fontan flow by mimicking both the respiratory and flow biomechanics. First, we built a respiratory simulator comprised of a thorax, abdomen, and a soft robotic diaphragm. Next, we designed an electromechanical control system to activate the diaphragm and recreate pressure changes mimicking regular breathing. Then we overlaid the respiratory simulator with a lumped parameter fluid model. This model, similar to physiology, during inspiration, the artificial pneumatic muscles contract inside of the respiratory and flow simulator to lower the diaphragm towards the abdominal cavity. This increases pressure in the abdominal cavity, pushing on the stored fluid inside of the abdominal compliance vessel. Conversely, the pressure in the chest cavity drops, allowing more fluid to shift into the pulmonary vasculature vessel from the abdominal compliance chamber that is pressurized. This results in an increased flow through the simulated Fontan shunt, as it is seen in Fontan physiology. Here you can see the implemented respiratory simulator that mimics the motion of the diaphragm and is such the main contributor to respiration. We are able to generate thoracic and abdominal pressures in the physiological range, and on the right side you can see a video of our simulator with integrated real swine lungs. As the diaphragm lowers, the swine lungs inflate with air due to the negative pressure. To integrate a flow loop into the respiratory simulator, we started with a rigid Windkessel compliance vessel that was representing the upper body vasculature. We mimicked the lungs in the chest cavity with 2 flow resistors and 2 compliance vessels that simulate the 2 lobes of the lungs. The abdominal vascular bed was simulated with a large compliant vessel and a flow resistor. To generate the physiologic flow through the simulator, we used fluid reservoirs that provided constant fluid pressures across the flow loop. Thereby, we could calculate the flow with the given equations and specify the engineering components necessary to realize physiological flow conditions. To enable detailed monitoring of our flow and respiratory loop, we included pressure and flow sensors beneath and above the diaphragm, as well as in our simulated cardiac return after the pulmonary vascular bed. Additionally, we included pressure sensors in the chest and abdominal cavity to monitor the breathing. Here you can see our integration of our flow loop into our respiratory simulator. To realize the complex flow patterns of the Fontan physiology, we segmented anatomical structures from patient data and 3D printed them to include them as hollow vessels into our system. Pulmonary and abdominal vasculatures are subject to changes in breathing pressures. To recreate this vasculature, we designed elastic compliance vessels made from silicone membranes. We calculated the required dimensions and silicone durometers using the given formula. This way, we were able to mimic physiological values for both the abdominal and chest compliance vessels. We then characterized the compliance vessels experimentally to ensure physiological ranges. Additionally, we explored how the compliance changes with more rigid vessel walls, which mimic pathophysiological conditions frequently found in Fontan patients. To recreate hemodynamic conditions similar to physiology, we developed an analog blood fluid using monoethylene glycol solutions. We characterized different concentrations in a rheometer to mimic the dynamic viscosity and density of blood at body temperature. Finally, we integrated ultrasonic flow probes and intravenous pressure sensors into the flow and respiratory simulator, which allowed us to monitor the system from our custom user interface. Here on the left, you can see an image of our finalized flow and respiratory simulator filled with the analog blood fluid, and on the right, you can see it in action. Upon overlaying breathing mechanics with the flow system, we see an impact of breathing pressures on the venous flow, which is representative of a Fontan patient. In this video, you can see how the diaphragm is lowered by pneumatic artificial muscles, increasing the pressure in the abdomen and decreasing the pressure in the simulated chest cavity. This creates a surge of blood that expands the lung compliance chamber circled in red. You can see some of the fluid shifts in the air bubbles, which were removed for experiments. With that, I would like to thank you for your attention, all authors, and especially David Fanstory for the contributions, Professor Ellen Roach at MIT and Dr. Pedro Del Nido at Boston Children's Hospital for their advising, and the entire Therapeutic Technology Design and Development Lab. I would also like to acknowledge our funding sources that supported this research: the National Science Foundation, the Charles H. Hood Foundation, the Muscular Dystrophy Association of America, and Muscular Dystrophy of Canada. Please feel free to reach out with any questions. Thank you.